This is why measurement of central artery pressure, which we are not doing often, but we have grants to do this in Sokoto that we are about to start, is relevant in addition to measuring the arm blood pressure, because it's a better reflection of the actual blood pressure. There are also functional abnormalities. For example, Blacks tend to have more impaired endothelium-dependent or independent vascular function. You know, we have what we call endothelial relaxant factors and so on. This tends to be more impaired in Blacks than whites. Next slide. The Blacks and large capacity vessels also tends to dilate less markedly in response to vasodilatation. And the bioavailability of nitric oxide is also low in Black vasculature than whites. You recall that nitric oxide is a vasodilator. So the bioavailability of this agent is lower in Blacks than whites. Next slide, please. Abnormal diurnal blood pressure variation is another important difference that has been observed between Blacks and whites. Blood pressure varies throughout the day, depending on the physiologic environment. But generally, in the night time, which is defined here between 12 midnight and 6 a.m., it is expected that blood pressure should fall compared to this time between 6 a.m. and 12 noon. And this fall is usually in the range of 10 to 20%. Normally, we call it dipping. So every individual is supposed to have dipping of blood pressure occurring at night time compared to daytime in the range of 10 to 20%. When individuals' nighttime blood pressure does not fall or fall less than 10% compared to daytime blood pressure, we call such individuals as non-dippers. And Blacks tends to have higher prevalence of non-dipping than whites. And of course, from straightforward and pathological implication, we know when the blood pressure is elevated for a longer period, then the target organ damage is expectedly going to be higher in such category of patients. Next slide. This abnormal diurnal blood pressure variation, that is non-dipping, has been linked to high dietary salt intake, salt sensitivity, low potassium, obesity, and apnea index in those with obstructive sleep apnea. Next slide, please. So let's consider obesity. We are considering obesity at this stage, not that the ones we have mentioned before have more contributory factors. I think the most important contributory factor is salt sensitivity. The next that actually explains the rising prevalence of hypertension in Blacks is obesity. Obesity tends to be more common in Blacks than whites, particularly Black women. And it is known that the adipokines sensitize human adrenocortical cells to angiotensin II mediated aldosterone release. And you see aldosterone increases tubular water and salt reabsorption. This is one of the mechanisms by which obesity causes elevated blood pressure. Most women with obesity also tend to have premature birth. And premature birth is associated with low birth weight. And you all know the concept of thrifty hypothesis that explains how low birth weight babies tends to be predisposed or have higher risk of cardiovascular diseases later in life, particularly hypertension and diabetes. So another mechanism through which obesity may predispose to hypertension is through low birth weight. Next slide, please. Obesity is also a contributory factor to non-dipping that we have already described, and also excess secretion of cortisol and aldosterone, as we have mentioned. Next slide, please. Obstructive sleep apnea is becoming a frequent problem. We are not doing sleep studies. Perhaps that is why we are not picking them up. But most patients with refractory hypertension tends to be obese. And obesity is a risk factor for obstructive sleep apnea. And this has also been recognized to be more common in blacks than whites. It is also a factor that causes non-dipping of nocturnal blood pressure, as we have earlier described. Next slide, please. What we want to highlight here is how salt sensitivity tends to interact with many other factors in terms of predisposition to systemic hypertension. For example, salt sensitivity and nitric oxide. Salt sensitivity tends to result in failure of nitric oxide to upgrade in order to increase when there is angiotensin II release or there's endothelin 1 release. Usually, normally, these are vasoconstrictors, and when they are released, you are supposed to have an upgrade of nitric oxide to counter the effects. But in people who are salt sensitive, this upgrading does not occur. Next slide. Salt sensitivity is also related to excess sympathetic drive, leading to release of catecholamines, which we know will also predispose or explain development of systemic hypertension. Next slide. To endothelin 1, a vasoconstrictor, and it tends to attenuate endothelium-dependent relaxation, and also, as we have mentioned earlier, causes non-dipping. So you can see that all the other mechanisms of development of hypertension tends to be related to salt sensitivity. Next slide, please. So putting everything together, what we have said so far, what are the major factors that are responsible for differences in hypertension in blacks and whites? They are salt sensitivity, obesity, renin-angiotensin-aldosterone system, obstructive sleep apnea, and abnormal endothelial response. And the various mechanisms by which these cause hypertension are listed. And the important ones are salt and water retention, increased aldosterone, increased angiotensin II, and increased endothelin. And there tends to be hypoactivity of RAS system, leading to low renin and low angiotensin converting enzyme, as well as low potassium level. They also increase sympathetic drive Non-dipping is a very, very important factor in the difference between hypertension in blacks and white. And we have emphasized decrease in nitric oxide, a vasodilator, in most blacks. People who are salt sensitive also tend to be predisposed to calcium-related excess hyperactivity, thereby causing increased peripheral resistance. And of course, insulin resistance, we have mentioned, that is why hypertension and diabetes, obesity tends to occur together, what we have been described as metabolic syndrome. And of course, we talk about low birth weight that explain development of hypertension in children who have low birth weight later in life. Next slide, please. So again, trying to summarize the differences between blacks and whites, you can see as far as salt sensitivity is concerned, markedly different. It occurs in Caucasian, but is markedly, more in blacks than whites. Low renin, more in blacks than whites. Then increased aldosterone, nocturnal dipping, absence of nocturnal dipping, is also more common in black than white, or nocturnal dipping is more in white than blacks. And of course, obesity is a problem globally, but we are having a more recent increase than whites. Next slide, please. So this is try to put all we have said together. When there is genetic predisposition to salt sensitivity, when such individuals are exposed to salt, usually in diet, they are unable, particularly blacks, to excrete this salt efficiently. Therefore, salt and water retention occurs. And when salt and water retention occurs, that leads to increase in plasma volume. And this simple diagram, which is not really a reflection of what happens, just trying to explain, the pathogenesis through sodium-potassium ATPase-mediated mechanism leads to release of calcium in the vascular smooth muscle. And calcium, we have mentioned, will increase vascular smooth muscle hyperreactivity, leading to increase in peripheral resistance. And we know that this can predispose to hypertension. On the other hand, the increase in plasma volume will increase cardiac output. So here you have an increase in cardiac output, here you have an increase in peripheral resistance. And we know blood pressure is a product of cardiac output and peripheral resistance. So hypertension, try to simply explain in this diagram, does occur. And of course, we have other factors, obesity through the various mechanisms that we have enumerated, and for the nocturnal dipping that we have enumerated, insulin resistance, all these will act putatively in causing elevation of blood pressure. Next slide, please. Some of these mechanisms that we have over the years have been described among Nigerians. And the most prominent in them is the issue of salt sensitivity that we have described. Okay. There is also concept of salt taste threshold. Blacks are not only salt sensitive, but they tend to have a higher salt taste threshold. In other words, at a certain taste, so a concentration of salt, that individual will say, oh, maybe white will say this salt is excess. Blacks will still perceive it as if, no, the salt is not enough. And that tends to predispose to higher consumption of salt and lead further to salt and water retention. Of course, we have not done genetic markers much in Nigerians, but we have shown that majority of many black hypertensives or Nigerian hypertensive have family history of hypertension. Next slide, please. Okay, the low renin that we mentioned have been described by Adewale and others in Ibadan. Adewale was also in Ibadan. Sympathetic drive has also been described, and these are mainly experimental, results or studies in animals. And we recently, even Oga has also, described this work by Hurt. He has communicated it. We are trying to probably explain that one of the reasons why the hypertension, we have a very high prevalence of hypertension in Southeast Nigeria, may be the effect of civil war that occurred, some decades back, leading to probably malnutrition in some women and low birth weight, and probably now manifesting. It's just, a hypothesis, so to say, for now. Next slide, please. Well, I think we have mentioned this. Next slide. Next slide. Good. So, what are the implications for treatment from what we have said so far? One thing we have emphasized is diet and obesity. So, and that makes lifestyle modification a very important integral part in management of hypertension in Blacks. And this table is showing the DASH dietary approach to stop hypertension, which all of us are familiar with. Next slide, please. So what is the best antihypertensive? Sorry, there's a typographical error there for Blacks. From what we have said so far, what is the best antihypertensive? We have mentioned DASH. It's integral. We can look at one group, consider what are the drugs in terms of, just look at the class of drugs. What class of drugs from what we have presented? You will all agree with me. We are talking about salt sensitivity, salt and water retention, plasma volume increase. So diuretics will have a cardinal role. And that is recognized in the current guidelines by the Nigerian Hypertension Society. I have a slide that is not here because I'm using the one I submitted earlier. So number one is diuretics. Number two is the calcium channel blockers.
Yes.
Number three will be angiotensin converting enzyme inhibitors and angiotensin receptor blockers.
This is number one. Number two.
Then, of course, we will talk about beta blockers.
Beta blockers.
We'll also talk about centrally acting antihypertensives, which sometimes we still have to use despite evidence of side effects. So the efficacy of low salt diet is confirmed by randomized trials. So the level of evidence is very strong. So level A. Combination of low salt diet with diuretics also considered to be very, very effective. That will be a form of monotherapy. However, we must mention that it is now recognized that almost 90% of Blacks hypertensives, as confirmed by randomized trial, even in Nigeria by OJ in Abuja, will require combination chemotherapy in management of hypertension. And this sounds logical because even from the pathogenic mechanism, you can see there are many routes to develop hypertension. It's like people going to a market or somewhere through various routes. If you want to block people going, if you close only one, a few people will still manage to go through the alternative routes. So clearly, it sounds reasonable that ideal treatment of hypertension will require combination chemotherapy. So what are the various options? The Nigerian Hypertension Society recommends first combination of diuretics with AC inhibitor or angiotensin receptor blockers or a beta blockers. It also recognizes a combination of calcium channel blockers with diuretics or any of the other agents we have mentioned. So by the time you juggle these combinations, you'll probably come up with probably about 10 agents, even from just 3 classes of drugs that we can use in treatment of hypertension. However, as we have mentioned earlier, we must recognize that as monotherapy, AC inhibitor, angiotensin receptor blockers, and beta blockers are not very useful in blacks compared to whites. We are not saying that they may not work, they cannot work, but they are not as effective as they are in whites compared to blacks. We should also recognize that some combinations are harmful. For example, you cannot combine AC inhibitor and ARB. That will cause hyperkalemia. It is also not very, very reasonable to combine calcium channel blocker and beta blocker. It may predispose to bradycardia. So, in essence, the pathogenic mechanism of hypertension helps us to identify what class of drugs to use and the various combinations. Combination chemotherapy is recommended. There's no hard and fast rule, but generally, when the blood pressure or systolic blood pressure is greater than 15 above target, the target is usually 130 or gold, or diastolic blood pressure above 10 millimeter mercury above gold, which is usually 80. So generally, if you have a patient presenting with 140 plus 15 or 80 plus 10 diastolic, then such a patient has to go on combination chemotherapy. Next slide, please. Good. These are the various combinations that I highlighted earlier. So I think we can move ahead. Good, not very clear, but it's just showing that not all combinations are very good, so we can move on. Next slide, please. Having said all this, permit me to deviate a little so that we don't think that the only consideration in the management of hypertension in blacks is pathogenic mechanisms. Most blacks have non-scientific factors that contribute to poor blood pressure control. And one of them is their poor knowledge of hypertension. For example, in this study we did in 2000, 90% of our patients who had hypertension believed that it was caused by too much thinking. And about 40% thought that it's caused by too much work. And we still have almost 10 thinking that witchcraft is responsible for hypertension. And you cannot blame them when somebody was very well the following day, a day earlier, and the following day just died suddenly without complaining of anything. This is a challenge that we also face and we should recognize in addition to highfalutin jargons about scientific issues. Next slide, please. Next slide. Okay. Next slide, please. Again, this slide is showing the poor knowledge, not only about the cause, okay, Almost all the patients believe that prayer can cure hypertension. This, we cannot dispute this, but prayer alone, when it is poorly understood, that can cause a problem. It's one of the reasons why many of our patients abandon their treatment. And we have to be well armed. This is not the major topic, so I won't dwell much on it, but all we are emphasizing is that beyond drugs, there should be a lot of counseling and education when we are managing a Black patient with hypertension. There are many other agents, garlic, onion, and so on, that people believe that can cure hypertension. Next slide, please. A generally poor knowledge, as we have mentioned here, we're just trying to quantify the knowledge, and you can see that most of them, their knowledge in terms of adequacy is less than 30%. Next slide, please. So we must emphasize that management of hypertension, please, counseling is very important. The interaction between the doctor and the patient is very, very important, because hypertension is asymptomatic. It's a silent killer. And I would really want to recommend that Neimeth should also, I'm very happy. I listened to your advert, and I listened to all the good work you are doing, you know, even free drugs and so on. But I think this issue of counseling and education is one area that we need to also go into. Concluding, the pathogenesis of hypertension in Blacks is multifactorial, and we have seen all the various factors. Secondly, these factors interact. So we have interaction between obesity, salt sensitivity, the RAS system, and so on. And understanding these factors is very important in coming with treatment protocols, and even in deciding on decisions on future therapy that would be very useful to us. So diet and lifestyle modifications remain very, very important. And as I have emphasized, we should also consider some of our own peculiar barriers to blood pressure control in our environment. Next slide. Next slide, please. So I want to thank Neimeth for the opportunity to make this presentation, and I want to wish all of us a fruitful and successful marking of World Hypertension Day. Thank you very much for your attention and audience.
Thank you very much, Professor Simeon Isezu. I must say that that was a very knowledge-packed session. It was very enlightening. You were able to take us through the classifications of high blood pressure, the burden of hypertension all over the world, and you broke it down to Nigeria, the prevalence and all that. And you even broke it down to the projections. About 2025, how about 30% of the world population would be hypertensive. And you talked about the unique case of hypertension in Blacks, how salt sensitivity and how the renin angiotensin aldosterone system, how it contributes to the unique pathogenesis of hypertension in Blacks. You also talked about natural selection. And you talked about the medications that are much more effective in managing hypertension in Blacks, principally the diuretics and the calcium channel blockers, as well as those combinations that might be harmful, including combinations of AC inhibitors and ARBs, which may lead to hyperkalemia, and the calcium channel blockers and beta blockers may lead to harmful bradycardia. So thank you very much, sir. I believe that we have all learned a lot today. These are just the summary of the little things I was able to jot down. I know there are much more that you talked about, and many other people have gotten it. So thank you very much, sir. We really appreciate your presence. I would like you to stay on, because we have some questions that we're going to ask by the end of the whole presentation, and I would like you to give us more insight on that. So thank you very much, sir. Thank you. Yeah. So right now, we would go over to our second presentation. We'll go over to our second. Those of you who drop your email addresses, we're going to send the presentation slides to you, so don't worry. So let's go over to our second presentation. Tola, please kindly take this off. Dr. Kayode, can you share from your side, or do you want us to share from here for you?
Yeah, let me set up for me.
Okay, so Dr. Kayode is going to be taking us next, and he will take us on. He's going to be taking us on isolated systolic and refractory hypertension, achieving BP goals with calcium channel blockers. So Dr. Kayode Adeshola is going to be taking us on that. So we'll just go right into it. So Dr. Kayode, over to you. Yeah. Please take down this one and enable Dr. Kayode to be able to share.
Can you see me clear?
All right, Dr. Kayode, yes, we can see you. You're live. Okay. We can see you.
Good afternoon, ladies and gentlemen. Wish us a very special, happy Hypertension Day as we celebrate the World Hypertension Day today. And I also want to appreciate the efforts of Neimeth Pharmaceuticals all over the years. I've been made ambassador of Neimeth on FitGuard. That's fighting the fight against hypertension for over 10 years now. And we see the efforts of the company as if they really know hypertension has become a permanent part of the world's health. So, I will want to also appreciate Prof, who has just concluded his presentation, has really enriched and has even beaten into some of my presentations. I'm really very happy that yes.
I think there's an issue with that. If this is not working, is there alternative?
One very interesting thing which I never learned from my hypertension hero in UCH. That was a Prof telling us that as far back as 1925, the cutoff line for normal was as high as 210/100. Sure, those of us that are much younger will find that very, very strange. I thank God for the body of knowledge. So in the next couple of minutes, I will be trying to talk on isolated systolic hypertension, the role of calcium channel blockers in achieving the goals of BP control. Next slide. Go to the next one. Likely dealt deeply with the issue of prevalence of hypertension. But like you said, I think the country would need to pay a lot of attention to the southeastern part of the country. If we're having a population of 61% in the urban area and 50-something in the rural,
okay,
having hypertensive, it is really a cause for worry. We all know that hypertension will still come with complications. So that's really a point to note. Otherwise, he has covered most of the prevalence. Next slide. Okay. Now, still talking about prevalence, let me just move to the next one. We need to take our time again. Now, it has also helped with the different classifications of blood pressure, depending on the system one is adopting. But the one he gave us, that from Nigeria, seems to be what we all work with now. And from the pre-hypertension stage,
off my
look at the figures we use, 120 to 129 as systolic blood pressure, and anything less than 80 for the diastolic BP. For the stage 1, talking of 130, 140 to 159, and the diastolic of 90 to 99. And the stage 2, of course, anything greater than 140 as systolic, greater than 90 as diastolic stage 2.
This my
Mind
the
what
mic,
I
yeah.
have on
So
the screen there, because I actually adopted some slides from a presenter before. Now talking about the treatment of high blood pressure. Yes, all patients with blood pressure above normal will need to be treated like Prof highlighted. We have the DASH, and then we have the, like some of us that have had the stint with family medicine. We know a lot of lifestyle medicine is being promoted these days. So the issue of healthy diet, reducing sodium intake, potassium supplication, increasing physical activity, limiting alcohol consumption, and losing of weight. For those who are overweight, especially our women, it's very, very germane in the management of hypertension. When we talk about the non-drug, non-pharmacological. Then talking about the pharmacological intervention, we're talking anything from the stage 1 or stage 2, as earlier mentioned, will deserve pharmacological intervention. We're talking of blood pressure treatment threshold for people with high blood pressure. For adults with confirmed high blood pressure, without confirmed cardiovascular disease and a 10-year risk of atherosclerotic cardiovascular disease, less than 10%. Blood pressure lowering medication is recommended from the BP of 140/90. For adults with clinical, those that have associated cardiovascular diseases, then it is advisable that we start medication even at a lower level, talking about anything above 130/80 or higher. A target of 120/80 millimeters of mercury, generally better than a higher BP target. Then we talk about, like I think Prof also mentioned something about a more continuous monitoring of the BP of patients that we see. These days, we're happy that a lot of people are able to access the home gadgets where they can check the BPs. So we talk about using self-measured blood pressure monitoring, to diagnose, assess, and activate patients with high blood pressure. When we do this, it helps us to get a regular measurement of the BP, as in outside the ones we take in our clinic settings. And what we are talking about, this gives us advantage to know when somebody has a sustained BP, or what is generally described as a white coat or hypertension of mask. A patient comes to the hospital and merely seeing you in the white coat, gets scared and BP goes up. Some will tell you that, doctor, I'm scared, that's why it's this or that. Then the principles of antihypertensive drug therapy are many principles upon which your decision will be based. Like Prof has deeply highlighted, we should always be very, very sensitive to the issue of hypertension in the society. And one more time, I want to even commend, because a lot of times, most of our people will not go to the hospital. When they go, they believe they don't have. Even when you are telling some of them, they will be shaking their butt, telling you, doctor, see, I'm this strong, I'm this big. Are you telling me I have this kind of hypertension and things like that? So all those outreaches and other programs out there are even more sensitive to catching our people than those that readily go to hospital to submit for health checks. So whenever we see them, we are advised not to delay drug treatment. Lifestyle changes, like I have said earlier, is of very, very importance, of high importance. Then following up the patient, depending on the level at which you are catching the patient anyway. But if it's a patient that you think the BP is still just mild or moderate, then you could place such a patient on relevant drugs based on your assessment, and then monitor the patient over the next 6 weeks to 6 months, correcting and reducing or adjusting your dosages and knowing when to add extra as in combination or to leave it as it is. Like Prof has told us the other time, when you have the systolic of over 15 above what is called normal, or that of the diastolic of 10 above normal, then we should be thinking of having a closer watch over that patient. I might need to introduce combination instead of the single medication. Then you talk like we have seen, thiazide is generally very good in the blacks and the elderly. The ACE inhibitors and the angiotensin receptor blockers, they're very good also, actually in the people with heart failure and post myocardial infarction, and other people with related diseases like diabetes and proteinuria. Then the calcium channel blockers is very highly recommended in the blacks and the elderly also. And then we talk about, in that group, there are two categories of these calcium channel blockers. We have the dihydropyridines and the non-dihydropyridines. As I continue, I will talk briefly about them and the difference and which one is of a better prescription value to our patients. And the beta blockers, as earlier spoken about. Then we also have goals. As per when you have the patients, we know that yes, the systolic especially rises with age in the patients. We know that people that are less than 60, our goal, what you want to achieve should be something below 140 over 90. And for those that are above 60, up to 150 over 90, though debatable by some authorities, but that will be the goal. It can be better than that. There are other people that we need to pay special attention to, the chronic kidney disease patients and the diabetics. And in the non-black, they use a lot of thiazide and all the other groups that were mentioned. But here in the blacks, thiazides and the calcium channel blockers tend to be the best performers. Then we must assess our patients on a regular basis until we're able to see that we have reached our set target. I mean, achieve the level which we want to. If the goal BP cannot be reached, then we must take things more seriously and think of other higher levels of management. Now, we're talking about calcium blockers. I just said just now that there are two groups of these, the dihydropyridine calcium channel blockers and the non-dihydropyridine calcium blockers. Yes, amlodipine is one of those dihydropyridine calcium blockers, and it's also called calcium antagonist or calcium channel antagonist. What it does is to inhibit the voltage-dependent L-type calcium channel of the cardiac and the vascular smooth muscle cells. And by so doing, there is an influx of calcium into the cells, and this kind of inhibits movement of the calcium through the calcium channels. That's what we mean by calcium blockage in the cardiac and arterial muscles, and thereby reducing contractility. This reduction in contractility will lead to a buildup of negative inotropic effect, and then the smooth muscle cells tend to relax and there's vasodilation, and this also tend to peripheral resistance reduction. And with this, the BP tends to get controlled. Calcium channel blockers are used as antihypertensive drugs and recommended as first-line BP drugs. They are particularly effective against large vessel stiffness, which is one of the common causes of elevated systolic blood pressure in the elderly patient. And it's also used in the treatment of angina. The metabolism of and duration of action. Calcium channel blockers are metabolized by the cytochrome 3A4, and their effects can be potentiated or inhibited based on what other drugs like rifampicin is known, for instance, to accelerate the breakdown of calcium channel blockers. And where that is done, it means effect is reduced. And other drugs such as the antihistamines, the protease inhibitors, immunosuppressants, antifungal, and grapefruit inhibits the breakdown. And in giving our drug, the calcium blockers to our patient, we also need to be careful when some of the patients, especially the elderly who have erectile dysfunction and drugs such as sildenafil or tadalafil or any of those groups, because it tends to have kind of addictive effects, thereby lowering the BP. And the half-life period is said to be between 30 and 50, and this makes it very convenient for someone to take just once in a day. So why are we saying the dihydropyridines, calcium blockers, are better than the non-dihydropyridines? The examples of the non-dihydropyridines include the verapamil and the diazoxide. And the major problem here is because they are more myocardial selective and they tend to reduce the heart rate. And we don't want a situation whereby bradycardia is added to the problems. So what we have here, they have a negative effect also on the SA and AV nodes and cause reduction in heart rate and contractility. Whereas the dihydropyridine calcium blockers, like examples include the popular nifedipine, the felodipine, the amlodipine, and the cadipine. They have more of muscular selectivity and less of cardiac. They're also indicated in the treatment of angina, like I earlier mentioned, and they do not suppress the AV conduction and do not interfere with the sinus atrial node automaticity in running the heart. They also activate the angiotensin system. Newer agents such as the amlodipine and the felodipine especially also have another advantage of having a slower starting of action but longer duration. And with that, it is very, very handy in achieving less severe hypertension, in our patients. So what are the indications for the dihydropyridine calcium channel blockers? Some of the indications will include.
Hello, sir. You've stopped screen sharing. Please.
What we have been talking about, that's the channel. We're talking about the hypertension. Yes, actually arterial hypertension, then isolated systolic hypertension, vasospastic angina, and then we also talk about coronary spasms, migraine headaches, renal phenomenon, and all that. And we now want to talk about the isolated systolic hypertension. I can remember very well throughout my medical school, and I'm sure on this in this gathering, I have quite a number of senior colleagues. What we were being taught was based on a more reliability on using the instead of the systolic, which is used today. It used to be the diastolic BP that was incriminated all through as per the most relevant hemodynamic parameter or predictor of prognosis in hypertensive patients. In those days, they would tell you you are sitting in your office and maybe as you seated, somebody just raised the alarm, oh, snake, 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 and you expect the systolic just could just go up and be affected, but the diastolic is more reliable. Most clinical studies particularly address the diastolic BP, and diastolic values were put forward as the goal, the major thing for checking and monitoring, and also for predicting. So but in the recent years, there's been a radical move to more of believing that the systolic blood pressure is of, if not greater importance, is as important as the diastolic blood pressure in predicting outcome and prognosis of what happens, especially in cases like risk of stroke. So the isolated systolic hypertension has been introduced for those subjects with elevated systolic BP in the presence of a normal or even lower than normal diastolic blood pressure. The condition is found particularly in elderly hypertensive, since the systolic BP is known to rise with age, and while the diastolic usually levels off or even tends to decrease in the elderly. So according to modern definition expressed in the GNC6 and 1999 WHO and isolated systolic hypertension guidelines, isolated systolic hypertension is has been taken a value of less than 140 over less than 90, and anything above that is taken, actually the systolic of 140 is taken to be the isolated systolic hypertension. The development of isolated systolic hypertension with increasing age is explained by deterioration of the arterial compliance, and this is commonly seen in the large coronary arteries. Several studies, including Framingham study, documented the risk of high systolic BP in particular, and less clearly, especially with stroke, as related to stroke, and maybe less clearly in ischemic heart diseases. Similarly, there was another study, the MR-FIT study, systolic BP was found to be a stronger predictor of outcome than the diastolic BP. The data for so far available indicate that low dose thiazide diuretics and slow and long-acting calcium antagonists are our first choice in tackling isolated systolic hypertension in our society here. Like in my hospital, I know a lot of my patients have benefited from the combination of low dose diuretics and the long-acting calcium antagonist amlodipine. I think the one we have in the market, Northwest, has both the 12.5 of hydrochlorothiazide and then the amlodipine 5 milligrams. So a slow reduction of systolic pressure in the most elderly patients is mandatory, and targets should always be, as well as systolic, be something 140 or below. Now we want to talk about refractory hypertension. What do we mean by refractory hypertension? Among patients with resistant hypertension, there are those whose BP pressure remains high despite all the remain high, uncontrolled in spite of normal medical therapy. Refractory hypertension is defined as BP that remained uncontrolled after greater than 3 visits to a hypertensive clinic within a minimum 6-month follow-up period. Resistant hypertension is defined as high blood pressure that require 4 or more medications for treatment. In the people that we tend to tag as resistant, you find out that you've tried even the combination up to the level of using about 4 different medications. So you term them as resistant. And this also includes whether the BP is controlled or non-controlled after use of 4 or more They are once you are getting to 4 drugs or more, they are termed as resistant hypertension. While the exact prevalence of resistant hypertension is unknown, but cross-sectional studies suggest that it includes approximately about 10 to 15 of the general hypertensive population. It's something very significant. Patients with resistant hypertension are at increased cardiovascular risk. Of course, that's very, very, very glaring compared to patients with more easily controlled hypertension based on the increased likelihood of having other cardiovascular risk, such as left ventricular hypertrophy, chronic renal diseases, and the obstructive sleep apnea, which Professor mentioned earlier. Refractory hypertension, what do we do? Combination, drug combination in resistant and refractory. Yes, like depending on the level of the hypertension, but generally we still will encourage, the patient will benefit from the use of diuretics, in this case as much as 25-50 milligrams daily. Of course, we also know there's spironolactone, the potassium sparing diuretic and antihypertensive. ACE inhibitors and ARB can be used also. Of course, the ever-present calcium channel blockers, which has remained very reliable over the years. Beta blockers, vasodilator, and the central acting agents are also not left out. In all this, we must be careful and know how that monitoring our patients is of great essence. Many of them, several will come complain of palpitations, some ankle swellings, drowsiness, lightheadedness, flushing, and so on and so forth. The one major one which I've observed severally in the clinic is this issue of ankle swellings, which patient will come and tell you before you started us on this, especially those that are very enlightened or those that have gone to Google and read about, come around and complain about noticing the ankles, swelling since taking the drug, and in most cases you reassure, you try and check, investigate them to be sure they are not having not kidney problems or heart, and then you reassure. But if they persist, then you have to try to see what you can do about the ankle swellings. Other possible side effects include some complaining of undue tiredness, postural hypotension, reflex tachycardia. Can worsen also angina in rare cases. So who are those that should not, or when we should not use the calcium blockers? People with acute coronary syndrome, people with persistent bradycardia, hypotension, aortic stenosis, and pregnancy, and then those that are known to be allergic to the drug. Then what other drugs will affect the amlodipine? That's the sample of our dihydropyridine calcium blocker. And as we're talking of here, commonly nitroglycerin, simvastatins, and any other drug that might affect either the heart or have antihypertensive effects. Adult dose normally 5 milligrams once daily. It can be up to 10. And of course, sometimes you need to titrate depending on the size of the patient, how fragile or small the patient. You can start with a dose of about 2.5. So patient doses can be adjusted according to patient's response as well. Generally, you also do titration over 7 to 14 days. Then clinical, like I said, if clinically warranted, titration will proceed more rapidly, so that provided the patient is more closely assessed. Of course, we know there are some patients that you will not even allow to go home at all. So your administration of the drug and how you monitor your patient depends on the condition and the level of BP the patient was discovered with. Use alone or in combination with other antihypertensive, it can be used alone, it can be used in combination. Usually adults doses when we use it in Nigerian pectoris between 5 and 10, maximally used with 10 milligrams per day. Then, in clinical studies, most patients with angina or coronary artery disease require 10 milligrams orally once a day. Dosage, like I've said earlier, should always be adjusted according to the condition of the patient. That is amlodipine, which is popularly available, very much available out there, and it's highly recommended. So I would really wish to once more wish each and every one of us a happy World Hypertension Day, and I want to thank Neimeth Pharmaceuticals for their choosing hypertension as one of those areas of their ethical medical concentration in their contribution to the pharmacological world of Nigeria. It's been quite a while they've been doing this, and we all know very well that a lot of our people are often discovered just by accident. When they are discovered at some outreach, or some people just pass and say, let me check your BP. Most of our people will not go until it's getting to this stage. Otherwise, they always come very lately when complications also are setting, or they are being brought in unconscious deeply after a stroke or something. So thank you all for today, for participating in this program, and we wish to have more and more of this kind of program. Thank you for having me on this program.
Wonderful presentation. It was very, very on point and very insightful. You talked about the principles of antihypertensive drug therapy, because there are principles to these things. Just don't pick any antihypertensive and give to your patients. There are procedures that are laid down, and you have shown us what principles we should follow. And amongst the things you said was that treatment should not be delayed, and delay could be fatal for the patients. So treatment should not be delayed for hypertensive patients. Although we always encourage lifestyle changes, but you also need us to understand that lifestyle changes alone might not be enough to manage hypertensive patients. So drug therapy should be instituted at a certain point. Then one key area you talked about was the appropriate follow-up by medical professionals, by the doctors, by the pharmacists, by nurses, and all the people who are involved in healthcare, that they should follow up their patients appropriately to make sure that they are achieving their target goal and that they are on their medication. We also summarize the GNC, which is the recent guidelines for hypertension management. Summarize the main points for us. You talked about the mechanism of action of calcium channel blockers and how the dihydropyridine calcium channel blockers, for example, amlodipine, which is what we have in NWAMAKA and in AMLO, are the non-dihydropyridines. And you talked about the indications for calcium channel blockers and refractory hypertension and all that. So we really, really appreciate this wealth of knowledge which you have shared with us. And we want you to stick around because we're going to have some questions for you. Thank you very, very much.
You can chat me on my WhatsApp. I'll be able to answer better.
Professor Isezu, for your presentations. So we have another presentation. We have two more presentations. They are going to be brief. I'm going to take one right now. Before we go over to the clinical pharmacist, Dr. TRICIA, but I will take the next presentation very briefly before we go over to our last presentation of the day. So let's just stick around.
Hello, Dr. Charles, please, we can't hear you. Can you speak louder, please?
Yeah, I thought so.
Can you hear me now?
No, it's not very clear. Not loud
Can you hear
enough.
me now? Is it better?
Yes.
Yeah,
Yes.
it's okay.
Okay,
It's
good.
okay.
So maybe I should, where did you stop hearing me? Maybe I should just recount what I said.
The whole thing, the whole thing.
The whole thing, okay. So I talked about thanking Dr. Kayode for his presentation, which was very, very, very insightful and to the point. He talked about the principles of antihypertensive drug therapy. And he talked about not delaying drug treatments for patients. They should be diagnosed hypertensive patients should be on treatment as early as possible. And although we always talk about lifestyle changes, he made us to understand that lifestyle changes might not be enough and that drug therapy is actually needed. Then follow-up, which is one area that may be lacking in our drug care in Nigeria. Patients should be appropriately followed up to make sure that they are appropriately taking their medications and that they are meeting their target goal for blood pressure control. He also talked about the newest guidelines, which is the GNC8 guidelines for hypertension management, and the mechanism of action of calcium channel blockers, talking about isolated systolic hypertension and refractory hypertension, and how the dihydropyridine calcium channel blockers like amlodipine, which we have in Amlova and Nodwet, how they are superior to the non-dihydropyridine calcium channel blockers. So thank you very much, Dr. Kayode. Please stick around for questions that we may have for you. We have two more presentations, which are going to be very brief. I will take the next one before we go over to Dr. TRICIA COOKEYGAM, who is going to take our last presentation for the day. So let's just stick around. Thank you very, very much for your audience so far. Thank you for your patience, and thank you for joining us. Tola, don't worry. Let me share my screen. Let me share from here. Tola. Okay, let's just go with this little adverts or Omtamin ginseng.
That is why I put in all the long hours required. But no matter how much you love doing something, it can really get stressful. Thinking about the style, managing your customers' needs, being creative, it all takes a toll on you and sometimes you're burnt out. That is why I started taking Pharm to help me relieve stress and boost my immune system. So when the days get long and your body gets weak, I have Hemodynamic to manage the stress while I keep pushing my dream.
All right, thank you very much, Tola, for that. So the next presentation is going to be on the topic diuretics. Are they still relevant in managing hypertension? Are diuretics still relevant? We know that diuretics are one of the most widely used medications in the management of hypertension. But currently there's controversy around its use. There's a debate around its use, whether it is still appropriate as first line or even second line medications in managing hypertension. We are going to look at some of the effects of diuretics on clinical endpoints in the management of hypertension. And we know that lowering blood pressure has been shown to reduce cardiovascular risk, morbidity, and mortality. And that's one of the main benefits of lowering blood pressure is to reduce the risk of stroke and heart failure. Most of the times, it's the hypertension itself, it's the complications that are the major problems. The complications that arise from hypertension are the major problems. And those complications can be reduced. The risk for those complications can be reduced if you can appropriately manage the blood pressure. And in many studies or in many trials in which there was an appropriate management of blood pressure, it was found that the diuretic, that antihypertensive therapy was diuretic based. So well, let us look at the effect of diuretic treatment on stroke morbidity and mortality. In the era of placebo-controlled trials, several studies attested to the efficacy of diuretics in reducing stroke morbidity and mortality. They also attested to the superiority or the superior efficacy of diuretic therapy over other antihypertensive medications in reducing the risks for stroke. And one of such studies was the second Australian National Blood Pressure Study, which found that fatal stroke occurred 2 times more in patients who were treated with an ACE inhibitor than in patients who were treated with a diuretic. So obviously the diuretic in terms of this endpoint was better. In the MRC trial in the elderly patients, hydrochlorothiazide and amiloride reduced the risk of stroke, whereas beta blockers will fail to reduce the risk of stroke despite a similar lowering of BP. So both the hydrochlorothiazide and amiloride, which are one combination, and beta blockers, they were able to reduce the blood pressure similarly, but the diuretic, the combination of the diuretic was superior in the sense that it was able to reduce the risk of stroke while the beta blockers did not. In the international nifedipine study, intervention as a goal in hypertension treatment, 25 milligram hydrochlorothiazide plus amiloride 2.5 milligram were just as effective as 30 milligram nifedipine for preventing stroke. In a large meta-analysis, which includes about 48,000 patients, Patti et al. Found that high-dose diuretic therapy reduced the risk of stroke by 51%, whereas therapy with beta blockers reduced the risk by only 29%. Diuretics, or thiazide diuretics specifically, were also effective in preventing the development of heart failure in hypertensive patients, as this large meta-analysis showed, which included 18 long-term placebo-controlled randomized clinical trials. And it showed that high-dose diuretic therapy reduced the risk of heart failure by 83%, and low-dose diuretic reduced that same risk by 42%. In another trial known as INSIGHT, the diuretic was much more effective than nifedipine in preventing non-fatal heart failure. Now, one of the most commonly hard-hit groups in terms of hypertension are the elderly. In fact, they usually say that hypertension is a disease of the elderly. It therefore means that any medication that shows superior efficacy in the elderly should be part of the first-line medication in the treatment of hypertension in the elderly. And that is where diuretic-based therapy also came in. So hypertension is much more common in the elderly, and in this age group, isolated systolic hypertension is particularly common. And several placebo-controlled studies show the efficacy of diuretics in reducing cardiovascular morbidity and mortality in the elderly. And there are also other meta-analyses which show that diuretics reduce the risk of coronary artery disease and all-cause mortality. The ALHAT study showed the superiority of diuretics over other antihypertensive patients in some secondary endpoints. And there are certain additional advantages of diuretics. Several studies show that diuretics prevent the development of osteoporosis and reduce the risk of hip fractures. In a randomized double-blind 2-year trial, Reed et al. Showed that hydrochlorothiazide slowed cortical bone loss in normal postmenopausal women. Schuf et al. Showed in a prospective population-based cohort study that thiazide diuretics protect against hip fractures, and that this protective effect disappears within 4 months after the use of diuretics is discontinued. Thus, in addition to their use to lower blood pressure, the thiazide diuretics also play a major role in the prevention of osteoporosis and fractures, and these are commonly found in elderly patients. So it also helps in preventing these conditions, osteoporosis and fractures, while helping them to appropriately manage their blood pressure. But like any medication, there are certain drawbacks. But as health professionals, we always weigh what are the positives against the negatives. And in this case, some of the drawbacks in the use of diuretic, like any other medication, is that diuretics may induce some metabolic alterations that are harmful. And the most common of which is hyponatremia, which is also seen in, particularly in elderly women. But this side effect can be prevented by the use of a low to medium dose of diuretics and by instructing patients to limit fluid intake. So it therefore means that low dose diuretics intake would help to minimize this particular drawback of diuretic. There is also a dose-dependent rise in cholesterol when using diuretics. So also low-dose diuretics in this case would be helpful. But the deleterious effect of thiazide diuretics on lipid profile has been found to be short-term, and they almost always disappear in long-term studies. So this is not really a problem on the long run. If patients are going to be using diuretics for chronically, this is not going to be a problem because it has only been observed in the short term, and in the long run, it disappears. Now, one of the most telling objections to the use of diuretics is that it increases glucose levels. But a study or studies found out that in those cases where diuretics increased glucose levels, there was another drug. There was a second drug involved, and that drug was a beta blocker, which has been found to impair glucose metabolism. The atherosclerosis risk in communities study assessed the incidence of new onset diabetes after 3 and 6 years in 12,550 adults who did not have diabetes. Patients who received thiazide diuretics were not at a greater risk for the subsequent development of diabetes than the patients with hypertension who were not receiving any antihypertensive therapy. But in this study, only subjects with hypertension who were also taking beta blockers had a 28% higher risk of subsequent diabetes. So it seems like there's a correlation between when a beta blocker is added to a diuretic, that is when the danger of increase in diabetes, new onset diabetes usually arises. Now, there's an explanation for the possible effect of diuretics or thiazide diuretics on glucose metabolism, and that is usually related to hypokalemia, which is one of the side effects of diuretics. Analysis of the SHEP data showed that 0.5 milli equivalent per liter decrease in serum potassium during the first year of treatment was associated with a 45% higher adjusted diabetes risk. However, potassium supplementation or combination of thiazide diuretics with ACE inhibitors or potassium sparing agents might prevent thiazide-induced diuretics. So in this case, what it's simply saying is that the effect of thiazide diuretics on glucose metabolism is linked to its effect of causing hypokalemia. But that hypokalemia itself can be rectified by using potassium supplements or by combining the thiazide diuretic with a potassium sparing diuretic. And when that is done, this effect is minimized. The combination of thiazide with aldosterone antagonist may not only prevent new onset diabetes, but also improve blood pressure control. So what are the recommendations for the use of diuretics? What guidelines, what societies have recommended diuretics for use in managing hypertensive patients? The European Society of Cardiology, European Society of Hypertension guidelines recommend that thiazide diuretics should be considered as suitable as beta blockers, calcium antagonists, ACE inhibitors, and ARBs for the initiation and maintenance of antihypertensive treatment. Another European position endorsed by the British Hypertension Society is that diuretics and calcium channel blockers should be first-line drugs in hypertensive patients aged 55 years or Black hypertensive patients of any age. And the famous JNC7 guideline states that treatment of high blood pressure recommends that thiazide diuretics should be the preferred drugs in quotes, most hypertensive patients, either alone or combined with drugs from other classes. Now, the study from which I got all these data concluded by saying that thiazide type diuretics are at least as effective as beta blockers, calcium antagonists, and ACE inhibitors in reducing CV cardiovascular outcomes. And that thiazide diuretics are particularly effective in preventing stroke and heart failure in hypertensive patients. And that they are very effective in the elderly patients. And that the combined use of thiazide-like diuretics with aldosterone antagonists may be worthwhile. And thus, thiazide diuretics should remain the leading agents in the management of hypertension. Now at Neimeth, we are taking advantage of these beneficial features of diuretics and to present to you a portfolio of antihypertensive medications containing diuretics for the optimal management of hypertension. But before I go into those products, let me just recap and try to link this presentation to the presentation of the former speakers. And we saw that in the presentation of Professor Simeon, how he said that the calcium channel blockers and the diuretics are one of the most, or should be used as the first line agents in the management of hypertension, especially in Black patients. And this correlates with the data that I just showed from this presentation, as well as the presentation of Dr. Kayode in terms of the management of isolated systolic hypertension, how calcium channel blockers are very, very effective in the management of such patients. Now, in terms of the diuretics themselves, we can see that they have very, very good outcome in terms of heart failure and in terms of the reduction in the risk of stroke, much more than other classes of antihypertensive medications, which is positive, positive benefits for the use of thiazide diuretics. And we have combined all these to create certain antihypertensive medications that will be beneficial for our patients. And one of that is Nodret. Nodret is amlodipine, 5 milligram and 7.5 milligram with hydrochlorothiazide, 12.5 milligram. And with Nodret, our patient is assured of adequate blood pressure control, even in the event of a missed dose, because Nodret has amlodipine, which has a half-life of about 30 to 50 hours, which means it can cover you for a 24 or even more than a 24-hour period. It protects against early morning surge in blood pressure. Early morning surge in blood pressure is an independent risk factor for cardiovascular events. And it has been shown that drugs that have a higher or a longer half-life have the tendency to protect against early morning surge in blood pressure. So with Nodret, you are assured of that. Nodret assures us 24 hours blood pressure control, protection against cardiovascular risk. It is compliance friendly because most of the time it's just one tablet in a day, and also has less side effects in terms of the management of pedal edema that is very common with the use of amlodipine monotherapy. So with Nodret, with the combination with the diuretic, that side effect is taken care of. We also have Mini Plus, which is a combination of prazosin 0.5 milligram and hydrochlorothiazide 12.5 milligram. And Mini Plus employs a two-pronged approach in the management of hypertension via vasodilation by prazosin and diuresis by hydrochlorothiazide. And the synergy of both drugs allow for lower doses of both drugs to be used with better results and less side effects. And Mini Plus is particularly effective in refractory cases of hypertension and also for elderly male hypertensive patients, because there is an added benefit in patients who have BPH or benign prostatic hyperplasia. So that is one of the advantages that Mini Plus confers. Then we have a Nomoretic, which is a very popular brand, which I would say is the first choice diuretic in the management of hypertension, especially in Blacks. which contains amiloride 5 milligram. And amiloride is a potassium-sparing diuretic. Remember earlier we said that one of the problems of thiazide diuretics is its effect on glucose metabolism, which correlates with its ability to cause hypokalemia. But when you combine it with a potassium-sparing diuretic, then it counteracts that effect. It counteracts that effect. So we have normoretic, which can be used by all classes of hypertensive patients without problems. Amiloride, a potassium-sparing diuretic, and hydrochlorothiazide, a thiazide diuretic. So normoretic provides the following benefits as first choice therapy in hypertension. It adequately manages blood pressure through controlled diuresis. There's augmented antihypertensive activity, eliminates the risk of hypokalemia due to the presence of a potassium-sparing diuretic, and also enhances compliance. Then we have Amloval, which remains Neimeth's trusted brand of amlodipine. And the features of Amloval or amlodipine, they were shared by both Professor Simeon and also Dr. Kayode in managing as first-line agents for the management of hypertension and even in patients of isolated systolic hypertension. So these are some of the references. So that is the end of my presentation. I would just want to implore us as medical professionals, as doctors, and as pharmacists who have the well-being of our patients at heart, that Neimeth International Pharmaceuticals PLC, we are in the business of providing essential quality medications that are effective in the management of hypertensive patients of all classes. And that is why we have come up with these medications, including Amloval, which is our amlodipine brand, 5 and 10 milligram, Norduet, which is a combination of amlodipine and low-dose diuretic. We have Miniplus, combination of praxocin and a low-dose diuretic. And we have, beautifully so, normoretic, the first choice diuretic for the management of hypertensive patients, which contains a thiazide diuretic recommended in the management of all classes of hypertensive patients as first-line agents, and also amiloride, which is a potassium-sparing diuretic, such that the problem of glucose, the effect of thiazide diuretic in glucose metabolism is nullified. So with these few points, I've come to the end of my presentation. And thank you very, very, very much for your audience so far. Thank you for being patient with us. And having sat through 3 presentations, we have just 1 more presentation to go and we will be done for today. So thank you very much. So at this point, we're going to take our last presentation. We're going to take our last presentation. That will be by Dr. COOKEYGAM. She's going to, Mark, can you share your screen from there?
Yes.
Okay.
Yes.
So she's going to be taking us on pharmaceutical care and hypertension. Pharmaceutical care and hypertension, because it's not just about the therapy, there's also the role of the pharmacist. The pharmacist plays a very, very important role in making sure that the patients take their medications and they achieve the goal of their therapy. So we're going to go over to Dr. COOKEYGAM, who is going to educate us more on how the pharmacists come into the management of hypertension. Over to you, Ma. Thank you very much.
Good afternoon, all professional colleagues, other healthcare professionals. Thank you for staying up to this time. I'm going to I'll be very quick about what I'm going to say, because the other 4 speakers have actually touched a lot on what I wanted to speak about. So my emphasis is going to be on pharmaceutical care, and then I'm going to rope it on with the management of hypertension. So this is my outline. I'm going to briefly take us through the evolution of pharmaceutical care, how it came about from the start of the pharmacy profession to pharmaceutical care. I'm going to define what it is, the philosophy of pharmaceutical care, and then hypertension. Okay. So this image, you probably be wondering, it looks like a bar. I'm sure one or two persons may probably say that it looks like a bar, but this actually was the dispensary way back in the 1900s. This was actually a dispensary of a pharmacist. So basically, what actually happened there was pharmacists would manufacture medications and patent them, and then they will now prescribe them and sell them to patients. Okay, so the apothecary model of the 1900s was equivalent to the pharmaceutical industry of today and the drugstore, as well as the primary health care provider, all roped in one. So what the apothecary model did in those days was equivalent to what I just mentioned, the drugstore, the primary health care provider, as well as the pharmaceutical industry. This particular model, the emphasis was on the product itself. The emphasis was the product and the process. The pharmacy had a defined social value at that point in time. The next model is the compounding model. This model started off in the 1945s, and it was all about the pharmaceutical industry manufacturing loads of drugs. Basically, what it did was it made the pharmacists to now compound. Most of the drugs that were manufactured were put together by the pharmacists and sold. And what the pharmacist did then was to educate the patient on self-care and drug use. The next model is known as the distribution model. This model determined the different stages on the settings of the pharmacist. This model has also brought about the amendment by the 1951 Durham-Humphrey Amendment. And what this was all about was, it was the introduction of prescription-only label status on drugs, as we can see. This amendment modified or altered the roles of pharmacists way back then. For the community pharmacist, it served as a channel for the distribution of drugs from the pharmaceutical industry. For the hospital pharmacist, it served as the hospital pharmacist managing drugs that came into the facility. But apart from that, the hospital pharmacist also participated in large volume compounding, teaching of nurses, believe it or not. We also taught nurses. Yes, we still do actually. We taught nurses and we participated in the pharmacy and therapeutic committee. This era also established a physician-pharmacist relationship way back then, as well as established what we know as the narcotics. You know, the narcotics are controlled drugs. They're now also in classes. So this amendment classified the narcotics where they are today as controlled substances. The clinical pharmacy model is the fourth stage of the evolution of pharmacy as a profession. And it originated, of course, most of our things originate from the US. It originated in the 60s. Here, the community pharmacists provided drug information through medication counseling, through consultation with generic substitutions. Generic, as we all know, is another brand from the main brand itself. They also prescribed and counseled on non-prescription drugs, also known as the over-the-counter drugs. At this time, the physicians maintained their roles in medication therapy outcomes, and then the hospital pharmacists provided, again, supportive services due to their knowledge in pharmacodynamics and pharmacokinetics. Pharmacodynamics is all about the action and use of drugs, while pharmacokinetics is about what our body does to the drugs. So in addition to the roles that the hospital pharmacists played in the hospitals, they also interpreted questions and validated drug orders. They monitored drug therapy, we still do up to today. They manage selected drug therapies like parenteral nutrition, which is a new concept in Nigeria, but it is some facilities actually offer it, not all facilities anyway. They also participated in what we call patient care rounds, which is synonymous with the ward rounds we know, and they still do report adverse drug reactions, basically, and that is also known as pharmaceutical pharmacovigilance. Sorry. Pharmaceutical care model is the fifth stage, and it's basically about the pharmacist being responsible for the clinical functions he or she performs. But these functions have a drug product as the foundation. So basically, you have assessing the patient, you have the care plan and evaluation. The care plan is basically the tools that we use in pharmaceutical care, and it involves resolving drug therapy problems, achieving the therapeutic goals, and preventing possible potential drug therapy problems. I would just like us to just briefly share with us the difference between the traditional drug dispensing and pharmaceutical care. In the traditional drug dispensing, the focus was on dispensing of the drug product, which we still do as clinical pharmacists, but we have gone beyond that. What we do, in addition to dispensing of the drug product, we also manage the patient and ensure that the clinical outcomes are achieved. The second difference is that our education and counseling, that was with the traditional drug dispensing, is technical. It's basically dispensing the medication to the patient, and we leave it at that. But for the pharmaceutical care, we go beyond that. We ensure that the patient, through so many means, we ensure that the patient adheres to the medication. We try to especially determine that there are no actual potential and actual drug therapy problems, which is the heart and soul of pharmaceutical care. The third difference is that the outcome of drug treatment is not monitored. That is with the traditional drug dispensing. But with the pharmaceutical care, we have so many methods. We try to find out, we're active in finding out so many methods of trying to monitor outcomes of drug treatment and therapy. The fourth difference is when patients take medications, even now, most of them, even though there are side effects or adverse effects, they don't bother. They just feel, oh, well, it's probably the disease condition that is, bringing these drug therapy problems. But the pharmaceutical care, now, the pharmacists or the clinical pharmacists in pharmaceutical care, we take our time to identify the drug therapy problems, and we have tools for doing this. We have tools. We try to find out whether the drug is too high, is too low, if it's necessary, an additional drug, if there's an adverse drug reaction with drug-drug interactions, drug-food interactions. There's so many drug therapy problems. We have drug disease. There's so many drug therapy problems we try to identify, to ensure that the patient benefits optimally from the drug therapy. Then the last difference is we're not responsible, that was in the traditional drug dispensing, we're not responsible for drug treatment. Once we see a patient, we dispense the medication, and probably, most of the time anyway, we counsel the patient, it ends there. But with pharmaceutical care, we go out of our way to ensure that the patient adheres to medication, the patient is not experiencing any adverse drug reactions, the patient is pleased with the treatment. There's so many things that we do on top of the basic traditional drug dispensing. So this brings us to pharmaceutical care. Now, pharmaceutical care, the definition which was espoused by Hepler and Strand, is the responsible provision of drug therapy for the purpose of achieving definite outcomes that improve a patient's quality of life. Also, in 2013, another European organization called the Pharmaceutical Care Network Europe They also came up with their own definition, which is basically the same as Hepler and Strand's definition. And it says that the pharmacist's contribution to the care of the individuals, the pharmacist's contribution to the care of the individuals is in order to optimize medication use and improve health care outcomes, which is basically the same as the first definition. So, as I had mentioned before in the definition, the definite outcomes include, there's so many of them, but these are the specific outcomes that most of the time we look for. We have curing the disease, i.e., if a patient has malaria, by the time the appropriate anti-malaria is given, the clinical and parasitological cures have been manifested. The second definite outcome we look out for are reduction in symptoms, i.e., we can use an example being asthma. For asthma, of course, the symptoms are eminent and prominent. So what we do, we teach the to correct inhalation techniques. We explain to them the role of medication. We try to identify the triggers, and we explain for those of them who have moderate to severe asthma, we explain to them the roles and the necessity of corticosteroid administration. Then the third definite outcome is slowing the disease process. Now I'm going to use diabetes mellitus. Hypertension, yes, has its long-term complications, but diabetes mellitus, the symptoms they're right there, So I'm going to use diabetes mellitus as an example. So in terms of slowing disease process, we advise our patients to reduce the risk of complications. We advise them to take their medications. We also advise them in terms of diet, in terms of exercise. We help to identify those diabetic patients who are at risk in the population. I help to identify undiagnosed diabetic patients, and we treat appropriately. Then the fourth one is the prevention of disease symptoms.
Yes.
I'm going to use the example of schizophrenia. For patients who are schizophrenic, we ensure that we educate them on the necessity of adherence to their medications, basically. And also in the advanced countries, i.e. the United States of America, certain states also license pharmacists to inject their patients and also vaccinate as well.
Yes.
Yeah, like every concept, there's a philosophy to it. And pharmaceutical care also has its philosophy. And the philosophy, as it is, that was also espoused by Hepler and Strand, has 4 basic components. And the components are social need, patient-centeredness, caring, and pharmacist responsibility. Now, for the social need, the basic concept there is that we must reduce the drug-related morbidity and mortality associated with medication. Okay?
Okay. Problem no.
Associated with medication. Okay? And just a minute, please. Okay, just a minute. Okay, so let's continue. Okay, and the social need is that we identify, resolve, and identify and resolve drug therapy problems, as drug therapy problems are the heart and soul of pharmaceutical care. The second component is patient-centeredness. We are meant to, as clinical pharmacists, treat a patient holistically, treat a patient as one. In so doing, we are administering, or we're looking at patient-centeredness. Okay, and to do this, we usually develop a therapeutic relationship with the patient. We do that because we have found out that when we develop a therapeutic relationship with the patient, it breaks down the barriers, and the patient is able to open up to you before you actually start sending the patient for lab tests and so many other things to help us with the diagnosis of the patient, breaking down those barriers opens up the patient to you, and the patient is able to tell you what his problems are, and then you can go from there. Then the third component is caring. Caring it consists of the assessing the patient's needs, what the patient actually needs, if the patient has the resources to meet these needs, and the last one is follow-up, which is very important. I think one of the speakers talked about following up of that particular patient. It's not enough for you to treat a patient and let the patient go. The pharmacists follow up, and we do that through so many means. Those of us who can afford it, we call the patient to remind the patient about the doctor's appointments, physician's appointments. We also call the patients to remind them if they need a drug refill, if they are adhering to their medications, if they have any problems. We go beyond that, and we also document most of these interventions we do. And then the last but not the least of the components is pharmacy responsibility. As I had mentioned before, the pharmacist is responsible for the outcomes of the therapy that is meant to be achieved. The ultimate goal in pharmaceutical care, as I had mentioned and I will keep on mentioning, is identifying potential and actual drug therapy problems. As we know, medications have their benefits and their risks. Medications to the body are poisonous unless they are taken to serve certain purposes. So most of the time, even paracetamol as it were, it has its own side effects. So what the clinical pharmacist does is identify the potential, that's drug therapy problems that may arise and actual drug therapy problems. And then the second ultimate goal in pharmaceutical care is to resolve these problems and to prevent the drug therapy problems from becoming actual. And we have our tools to do this. I'm not going to, the previous speakers had spoken on hypertension. The only thing I'm going to add now is that when the patient is being checked, or when the patient BP is being checked, it's after 2 or 3 visits. You know, a patient doesn't just come to you, you check the blood pressure is high, and you start dispensing antihypertensive. No, after 3 consecutive visits, the patient may now be termed hypertensive. And then I also decided to put 2 classifications side by side. Of course, we all know about the GNC classification, but if you ask me, I would have preferred the American Heart Association because they have lowered their numbers. As we can see, they have lowered their stage 1 numbers to 130 to 139 over 80 to 89, as opposed to JNC and even the JNC 8 classification, which still leaves a stage 1 hypertension at 140 to 159 and 90 to 99 millimeters of mercury. Okay. Our previous speakers have spoken on this extensively. They concentrated on calcium channel blockers and thiazides being the preferred mode of treatment for the African descent without chronic kidney disease. Of course, we know that the goal for patients below 60 is for their BPs to be less than 140 over 90, irrespective of whether they're diabetic or they have chronic disease. For the elderly and those over 60, we call them the Diuretics, without kidney disease or diabetes mellitus, the target is less than 150 over 90. And for the elderly over 60 with comorbid diseases, their targets are usually less than 140 over 90. Yeah, hypertension, as we know it, consists, well, basically divided into the primary and secondary hypertension. For the primary hypertension, 90% of it is unknown, but the risk factors we do know, and for the primary hypertension, the risk factors are divided into modifiable and non-modifiable. For the modifiable, which means something can be done about it, excess salt. The previous speakers have spoken on excess dietary salt, poor diet and obesity, excessive alcohol consumption, lack of physical activity, we do know that, deprivation and social economic status. Several studies have shown that low social economic status is correlates with a high increased risk of hypertension. And then mental health and stress. I will not emphasize that enough. Mental health and stress, as it is now, Nigeria of today, you can imagine what it's doing to so many of us. And then the non-modifiable factors, which means that nothing really can be done about them, are the age, the ethnicity, genetics, and gender. Especially if you're a male, males, their risk of developing hypertension is much higher than females. The second causes, another cause of hypertension, which is the secondary hypertension, are listed here. The first two speakers had spoken on sleep apnea, the correlation between sleep apnea and hypertension. Drug-induced or related causes. We have drugs such as the oral contraceptives. Yeah, we have drugs that are used to cause schizophrenia, used to treat schizophrenia. Yes, most of these mental illnesses, some of them also cause an increase in blood pressure. Then chronic disease has been talked about. Primary aldosteronism has to do with the kidneys. Renal vascular disease is when the artery of the kidneys has been blocked, and then it eventually leads to high blood pressure. Chronic steroid therapy, Cushing's, all these are hormonal issues, and they also cause increased blood pressure. Please permit me, I'm trying to be as fast as I can. In the management of hypertension, it has been spoken about, so I'm going to skip this slide. Yes, now pharmaceutical care. Now, what we do, our goals really are specifically hypertension, because that's what we're talking about today. We try to maintain target blood pressure. We try to improve the patient's adherence to medication, i.e., for those patients who are on 2 or 3 medications, we try to look for those medications that are combo. Combo means 3 or 4 or 2 or 3 ingredients in one pill to reduce the pill burden for the patient. We also try to encourage the patient to attend the clinical appointments and, of course, the lifestyle modifications, which I'll touch briefly as we go on. We also, the pharmaceutical outcomes also are to improve the quality of life. And then we try to educate our patients on the disease. It's important for them to know what disease is about, the complications and the consequences of lack of adherence to these diseases and how it's to be managed. And then we help the patient develop a positive attitude towards hypertension. We do know that for a lot of hypertensive patients that are ignorant in terms of knowing that medication is lifelong, most of the time when a particular medication or the medication they're given has been exhausted, they stop. For IE, I do a lot of medical outreaches, and we do notice that when we see patients whose blood pressures are extremely high, when you ask them, they said that the medication that they were given at the last medical outreach had finished, and they didn't know they were meant to continue. So these are things we need to do. We try to tell them about the positive attitude about hypertension. And for those who feel that lifelong medication is cumbersome, I tell my patients, why don't they just sack their minds and look at popping pills, daily pills for the rest of their life as vitamins. Like a lot of us on vitamins you take every day. So they should look at hypertension in terms of popping those pills daily as vitamins that the body needs, kind of. But it's the antihypertensives are for reducing their blood pressure. They're just trying to psych their minds, because it's not easy for patients to be on medications lifelong. And then we try to improve the patient's satisfaction with the treatment they have gotten, especially when the outcomes are visible. They see that their blood pressures are being reduced. For those who had headaches and other complications that have been abated, they find out that they're no longer there, so they're satisfied with treatment. And then, of course, we try to reduce adverse drug reactions. Some of the speakers had spoken on interactions, drug interactions, drug food like grapefruit juice and amlodipine. There's an interaction between them. Amlodipine and ferrous salts, believe it or not, there's an interaction between those two. For our pregnant women, I'm in obstetrics and gynecology, so when our pregnant women come with high blood pressure and we give them the methyl dopa, we always advise them to give a space between the methyl dopa, consumption of the methyl dopa and the ferrous salts, because there's a compensation reaction between both. And then, of course, we try as much as possible to look for the most affordable antihypertensive for the patient. We do know that there are some antihypertensives that are more expensive than others. And even those, the generic in quote, they also do the same thing. So those are part of the things we do as clinical pharmacists. Now I'm going to quickly go through this. The management of hypertension through lifestyle modification is a two-pronged approach. You have the non-pharmacologic intervention and the drug-focused intervention. The past speakers have spoken about it. The only thing I'm going to add here is that studies have been shown that administration of calcium supplements daily, there's a significant drop in the blood pressure. Studies have been shown, and if you do want them, I could send you the references for them. Especially for our women who are menopausal, it's a dual benefit to prevent osteoporosis as well as reduce the blood pressure. So calcium is a plus. It's a plus for hypertensive patients. Of course, when we're talking about foods, there's an image there that I've posted. I think it's self-explanatory. But the only thing I'm going to point out is that the vegetables, whole grains, nuts and seeds, in fact, the food items on the left, if you notice, you require more of the servings than the ones on the left. On the right, the ones on the right, you are meant to take little of them from the servings. You can see like the meat and fish, and poultry, 2 or less servings. But on the opposite side, the more the foodstuffs there are more beneficial to you. The drug focus, I'm not going to talk on them because the previous speakers have spoken on them. The only thing I'm going to talk about is centrally acting methyl dopa, centrally acting agent. Yes. For our pregnant women, this is what they use. They also use nifedipine, but methyl dopa is what they use. And as I had mentioned before, we keep on talking about the interaction between methyl dopa and ferrous salts. Of course, we have the calcium channel blockers and we have the thiazides as well. I'm not going to expatiate on it because it has already been dealt with. Specific patient counseling, I had mentioned it before. We counsel our patients on the need to adhere to medication because of the damage to major organs. We emphasize on lifestyle modification and that medication is lifelong. We also, for patients who probably on just one antihypertensive, depending on if they're non-dippers or dippers. The Prof had mentioned it before. For non-dippers, which means your blood pressure doesn't rise, doesn't drop when you're sleeping, it's advisable for you, or we advise them to take it in the evening. But for those who are dippers, which means your blood pressure crashes when you're sleeping, it makes sense for them to take their medication in the morning. And then for diuretics, we advise our patients to take in the morning because of to avoid nocturnal diuresis. For those who have to take the diuretics twice a day, then they take it in the morning and then later on, maybe 12 hours after that same day. And then we discourage our patients from mixing orthodox medicines or preparations with herbal, because we do know herbs and medications as well, even though they're not, most of them are not standardized, but they're usually the interactions. So we discourage our patients from co-administering both preparations. For the ACEIs, we for our patients, especially the obese ones who have the dry cough, of course, we switch to the ARBs. For the methyl dopa, again, we've talked about pregnant women, but also our pregnant women who have a history of depression, methyl dopa is contraindicated. And of course, for our men who we don't even prescribe methyl dopa because of erectile dysfunction. Very important. And then for the cardioselective beta blockers, we advise them not to discontinue it abruptly because of rebound hypertension. So why is pharmaceutical care necessary in the management of hypertension or any other chronic disease for that matter? Hypertension is a chronic condition, which we all do know. The prevalence in the society is high, and non-pharmaceutical care interventions have been proven to improve the clinical outcomes of management. Thank you very much for listening. These are my references. Thank you for listening.
Thank you very much, Dr. COOKEYGAM, for that wonderful presentation. Thank you very much for bringing in the pharmacy aspect. Can you hear me?
Now?
Okay, so thank you for bringing in the pharmacy aspect to it, pharmaceutical care, the contribution of the pharmacist. I think it is invaluable. The information you've given us is invaluable. You talked about the evolution of the pharmacy practice and pharmaceutical care. Talked about dispensing, patient management, evaluation, and counseling. And also one very key one, which is the identification of drug therapy problems, because that itself can be very dangerous for the patients, trying to treat the patient and then drug combinations now being a cause of other problems. So that is where the pharmacist comes in as well. We talked about pharmaceutical care philosophy, which includes the social need, patient-centeredness, caring, and also the responsibility of the pharmacist. We talked about the modifiable and the non-modifiable risk factors for high blood pressure, with the modifiable being some like excessive salt intake, poor diet, and alcohol. And we can see how educating patients on this regard can help them to reduce their risk of getting hypertension. And also the non-modifiable, which is pretty much what we cannot do anything about, which includes the age, ethnicity, and genetics. You also talked about the causes of hypertension, the primary causes and the secondary causes of hypertension. We know that most hypertension is primary in the sense that the cause is really not known. But for some, there are specific causes, which include sleep apnea and drug-induced hypertension, chronic kidney disease, and primary aldosteronism. Those are some of the things you talked about. And then you also talked about pharmaceutical care outcomes, which include reduced pill burden. And this is something that is very, very dear to us. It's at a focal point in Neimeth's design of antihypertensive medication, because we know that hypertension is a chronic disease that the patients are going to be taking it their medications most likely for the rest of their lives. So we want to simplify the process for them. That is why we have single pill combinations like our Nomoretic, like our Nodwet, and like our Mini Plus. These are combinations of drugs, 2 drugs in one combinations that simplifies the pill burden. You also talked about how pharmacist intervention can help to improve adherence, how it can also help to improve the quality of life, and the very, very important aspect of patient education, which our first speaker, Professor Simeon, harped on as well, that education of the patient is very, 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 very necessary. As he showed in some of the studies that he did personally, I could see his name on those references, where some patients actually believed, up to 10% of patients believe that witchcraft can be a cause for hypertension. So we can see that patient education is very important, and the pharmacist also comes into play there. And also helping the patient to develop positive mental attitudes towards hypertension. So lastly, you talked about specific patient counseling, which includes, for example, they should take their drugs the same time every day, and not to mix orthodox and non-orthodox medication, and also to take diuretics in the morning because diuretics, they cause increased urine production. If they are taken at night, they might disrupt the patient's sleep, and that might lead to other problems. So these are some of the areas in which the pharmacist helps to improve the positive outcome for patients, for their patients. So thank you very, very much, Dr. Tricia, for that presentation, that wonderful presentation. I believe that we have some questions that we've jotted down, that we've noted down, and that we want to ask our resource persons, the guests, from Dr. Simeon, Professor Simeon, to Dr. Kayode, to Dr. Tricia, and even myself. If you have those questions, please, in the next, just give us in the next 3 minutes, you can ask those questions. Let's just take one more advert from our products. So over to you, Adetola. Just give us one advert for our products, then we go over to the question and answer segment before we close this session. So thank you very much once again. Adetola, over to you. You can put your questions in the comment section, or you can speak up if you want to. thank you once again for your patience with us, for participating in this webinar. Please let us have your questions. Whatever questions you have for our resource persons, our guest speakers today, please let us have them. I believe Professor Simeon is still around, Dr. Kayode and Dr. COOKEYGAM, they are still around. So if you want to ask any question, you can speak up or you can put it in the chat section.
Hello.
Yeah, we can hear you.
This is Dr. K. Adeshola.
Okay, sir. Go ahead, sir.
Yeah, in the chat room, I noticed there was a question which I think I've also thought about in the past.
Okay.
Somebody's talking about there's the need for a 25 milligrams stroke 10 milligram Nordic.
Okay.
Comment about that. Can you all hear me?
Yeah, I can hear you.
Yeah. You know, what we have currently is amlodipine 5 and then the low dose HCT of 12.5. We also have the second one, which is amlodipine 7.5 with the same 12.5 HCT. So I'm sure this person must have also had some experience with NWAMAKA and thinking about it, because sometimes the 12.5 stroke 5 or 12.5 stroke 7.5 is sometimes not adequate in some patients. And you're either forced to want to increase more of the amlodipine aspect. But if you are giving to, that means you are increasing both the amlodipine and the diuretics there. And so when somebody amongst the participants put this, it attracted my attention that yes, as one of those I've been using this for patients for some years, I think it's right time we also look at that. But what the person is suggesting is 25 of hydrochlorothiazide and 10 milligrams of amlodipine as a combination.
Okay.
So it's left for Neimeth to look into that.
Yes, sir. We're going to look into that. But currently, like you mentioned, we have the 7.5 and the 12.5 milligram. And the 7.5, 12.5 is as good as 10 milligram of amlodipine and 12.5 milligram of hydrochlorothiazide. So it's found out that there was really no measurable difference when 7.5 milligram of amlodipine was used as against 10 milligram of amlodipine. And also because we want to keep the hydrochlorothiazide as low as possible, that's why we're leaving it at 12.5 milligram. Although the 7.5, 12.5 is not in the market right now, but we are ramping up production of it so that doctors can have more flexibility and more options in managing their patients with NWAMAKA. As for the doctor who asked for 10 milligram, 25 milligram, you could just easily as well use 2 tablets of current NWAMAKA 5 milligram, 12.5, and that will give you your 10, 25 milligram that you're looking for. But we have taken that feedback into consideration and we'll look at it. So thank you very much for that.
So please take note of all the emails that have been sent. Most people want to have the copies of the lecture.
Yes. So for those that joined our program and sent their emails, we're going to send you the presentation slides. So if there are any more questions, we can take them. If they're not, then we would like to have our ED sales and marketing from Rosalind Oputa to say a word or two before we close this session.
Okay, Charles. Hello, Charles.
Yes, I can hear you, sir.
Okay, there's no question for me, but let me just make a comment on one issue raised by the pharmacist that presented.
Okay.
Very good. She showed a slide that showed a lower cutoff point that is proposed by the Americans, which is currently not yet internationally adopted, but in line with the earlier mentioned fact that the cutoff point has been dropping since early 1925 or so to date. And it is not unlikely that we may still have a cutoff point lower than 140/90. There are points for and points against. The point for lower cutoff point is that the optimal blood pressure is still below 120/80. So between 110 and 120, obviously, there's no doubt that there's still increased cardiovascular morbidity at higher level compared to lower level. However, we have to take the public health aspect of it. How many cardiovascular diseases will you prevent by treating more patients? When you decide to treat those that are if you choose 130/80, the implication is that we are going to treat a lot more member of the population. And that has economic implications as well. And you may not prevent significant number of stroke, heart failure, and so on. So for now, it's still not yet low, but as you rightly mentioned, we eventually, as time goes on, who knows, the American proposal may be adopted. This is an interesting point. I just thought I should also dilate on that. Thank you very much.
Thank you very much, sir, for that point. Thank you very much for that point noted. I also believe that Dr. COOKEYGAM has noted the point as well. So we have Waliu Ogumba raising his hand. He wants to say something. You can unmute yourself and ask your question or make your comments. Go ahead, Waliu. Hello, Waliu.
Hello, can you hear me, please?
Yeah, I can hear you. Go ahead, we can hear you. Are there any other questions from anyone else?
Can you hear me?
Okay.
Can you hear me? Hello?
Yeah, I can hear you. Go ahead.
Oh, okay. So that was the reason why I was suggesting 10/25 milligram node weight.
Okay.
Because, and just like Dr. Adewale said, combining, having a combo drug is one of the drawbacks is having to increase the dose of one of the drugs when you not desire to increase the dose of the other one.
Yeah.
And that's why I don't really like combo drugs. In case I want to double my amlodipine to 10 milligrams to maintain my hypertension. So that was why I was suggesting that. From Dr. Adewale's presentation, the duration of follow-up of our patients with BP, I think if I did hear him very well, that 6 weeks for follow-up before target is being reached, to me, very, very the 6 weeks of follow-up becomes very long, because most of our patients, what you observe is that when you give them a prescription and they get to the pharmacy, if you give them a 6 weeks appointment, what they are going to be dispensed will not be up to 6 weeks, or they don't have enough money to buy their drug up to 6 weeks. They bought up to 2 or 3 weeks, and they are coming back in 6 weeks. And because most of them, they are not even aware that their drugs must not be stopped at any point in time. So they are coming back after 6 weeks, and they have taken their drugs for only 3 weeks. So when they get to you and you take their BP, the BP is up. BP is up. And some of them, even if you ask them to come with their drugs, when they come, you see that they either come with empty sachets, and when you ask them, oh, I just went the last dose yesterday. If they come with new sachets, they will do, so you know that the compliance is very, very, very poor. So the follow-up of our BP patients becomes very, very cumbersome. We are not sure whether our patients are taking their drugs regularly, whether they are taking it as a when due, whether they even have the financial muscle to even purchase most of these drugs. The elderly ones among them, the children send money to them monthly to purchase their drugs. They have to eat out of the money. So what I'm saying is that the economic challenges the patients are facing is also making follow-up very difficult, because they are not taking their drugs regularly. So we need to look at the issue of the duration of follow-up. So for me, I follow up my patient 2 weekly, because I know no matter how, they will still be able to purchase their drug for at least for like 2 weeks. So when they come, the target is not yet reached. If there is any need for us to adjust, we adjust. So 6 weeks of follow-up to me seems to be too long. But yes, if you find in most of our general hospitals, because of the patient load, you find out that even 3 months of follow-up, you start the patient on a new medication, you ask the patient to come back after 3 months. For heaven's sake, that to me is so long. So that's for Dr. Adewale. Then the issue of Dr. COOKEYGAM, Aldomet not given to men at all. I don't think that is entirely true, because there are some very, very terrible BP that will come across in general hospital settings that most of our first-line drugs will not be able to handle. I'm sure people that are involved, they understand what I'm trying to say. So when you give drugs like Aldomet, it's not intended to be given for a very long time. It's intended to be given for a short time to control the BP in a matter of 48, 72 hours, depending. And once the BP is well controlled, you can now discontinue the Aldomet, because the libido lowering effect of Aldomet is not even only in men, it also happens in women. So what we do is to use the Aldomet for a very short time, and once the BP is controlled, we can now discontinue the Aldomet and now switch over to other drugs. So that is the way we use the Aldomet. It's not as if entirely we don't give Aldomet at all. It's still very, very valuable in control of BP. Then the prayer in BP management, like Prof has said, very interesting. I'm really very happy with the presentation of Prof concerning the attitude and beliefs of our people with BP. Yeah, I have it, and just well, I'm tired with these many drugs for over so many weeks. I've been praying about it, and I think that should be able to handle it. Yeah, I would just tell them, please, my brother, yeah, there's a place for prayer, but without your medication, I don't think your prayer will work. I don't think so. So I want to thank Prof for the experience, and all other speakers. That's my just contribution for now. Thank you very much.
Thank you very much, Dr. Waliu, for your comments. Thank you. They are noted. Dr. Kayode and Dr. COOKEYGAM, you were mentioned in these questions and these comments. So if you'd like to respond, go ahead.
Yes, I want to respond briefly. Most of the things said by Dr. Waliu, they are very, very correct. And of course, maybe he missed the time at the point when I said it depends on the condition of that patient. It also depends on the BP you are getting. If not, there won't be places for things like apresolin, adrenaline, sublingual, nifedipine, and all those that we have to use sometimes in an emergency situation when you think this patient's BP might just kill him at any point. And again, it's not every patient that walks in that we even allowed to go home. There are some that you have to keep
Yes,
on
yes,
bed right
yes.
away because of whatever clinical assessment you have made of the situation. So talking about the 6-week thing, yes, it's quite a long time for you to see a patient of BP a second time, but it depends on, is that patient just being discovered first time? Is it somebody that's been used to taking drugs? Is it somebody that's just, a walking and by accident discovered? So it depends on a lot of factors for you to make up your mind. And again, that rarely happens in a private hospital, because private hospitals, the patient load is lesser. So we have more time. And again, the distance between you and the patient. Are you telling that patient when you get to Abuja, make sure you go to the nearest hospital and get this thing monitored, call me 3 days or keep a record of something? It's all depends on a lot of, factors. That's just it. So the 6-week thing is not meant for just everybody. Depends on, and like he said, when you get to the general hospital or the teaching hospitals and you see them, you still have to apply all these variables that I mentioned. That's just the way it is. Thank you.
Thank you very much, sir, for that comment, and we really appreciate that. Now, there's a question here. Any of the doctors can take it, or Professor Simeon can take, or Dr. Kayode, or even Dr. COOKEYGAM. The person said, my question is, if it happened that someone has low blood pressure, what drug are they going to take? If the patient has low blood pressure, what drug are they going to take?
I don't know if Prof is still around. Yeah, we'll take it.
Oh.
So,
hello.
Yes, Professor Simeon, we can hear you, sir.
Okay. Low blood pressure as a primary problem is extremely rare. So virtually every low blood pressure is caused by another problem, and most commonly medications. So if the question is in terms of, if I have a patient on antihypertensive and the patient develops low blood pressure, that in that perspective, I think the question is quite understood. In that case, of course, the first thing is to stop the antihypertensive medication, because otherwise you can develop what we call watershed syndrome, whereby virtually all the central functions in the brain are depressed as a result of hypoperfusion to the brain. And then the other measures will now be put in the use of fluids such as normal saline, which can expand the plasma volume, increase the cardiac output, and increase the blood pressure. And really, sometimes you may have to use some agents that will cause direct vasoconstriction and increase the blood pressure, and of course, other supportive treatment that is equally given to patients with low blood pressure from other causes like shock and so on. Otherwise, very, very uncommon. Some patients, the normal blood pressure is like other biological variables. It has a wide range. It's like height. Some people are 1.7, some are 1.6, some are 1.4. Everybody is normal. So you have some people that have blood pressure of 90/70. That's their normal blood pressure. It's not low, as long as they are not symptomatic. So because we have had some patients who come to you, oh, my blood pressure is 90/70, and these people are probably more than 40 years old, 50 years old. That is their constitutional blood pressure. And as I show in the graph, the lower the better. One of the things we have observed is most of the people who are 80, 90 years old, they tend to have low blood pressure. As long as the patient is asymptomatic, just counsel the patient. There's no need for treatment of a patient whose low blood pressure is in the lower range and is asymptomatic. Thank you. My other colleagues may want to add a few things.
Thank you very much, sir. Thank you very much, sir, for that. So the answer to that question, I think the answer is very, very simple and well understood. So any other questions or any other comments from our guest speakers before our ED sales and marketing says a word or two? Any other questions?
Yes, please.
Okay, ma. Go ahead, ma.
It's actually a comment.
Okay.
Yeah, I wonder why, regarding males taking methyl dopa, when we know there's a known adverse reaction to it, there's so many other antihypertensives that could be taken. Why would anyone want to prescribe methyl dopa for a male when we know the expected adverse effects? There's so many other drugs that can be taken that are equally as cheap as methyl dopa. I'm just thinking from the top of my head anyway. I'm actually directing that comment to Dr. Waliyu, I think, because he was saying, he was kind of counteracting what I said. So I'm still just trying to wrap my head around it. Why it would be prescribed when there's so many other antihypertensives that don't have that particular side effect.
Okay. So Dr. Waliyu, Dr. Kayode, or Professor Simeon, the question is up for you.
Yeah, thank you.
Any of you can take it.
Yes.
Hello.
Yes, sir. Go ahead.
Yeah, what I said was this: it's not absolute in males, and that the libido lowering effects also affect females too that take Aldomate. Now, what we do is to use Aldomate for a very short time. There are some level of BP in the emergencies that will come across that many of the other causes of antihypertensive will not be able to control within 72 hours or thereabout. So we employ Aldomate for a very short time. 2-3 days, BP is down, then we switch over to other. And one good thing about Aldomate, the side effect is that once you withdraw the Aldomate, the libido lowering effect reverses also.
Okay.
So it's not as if it's going to be taken for a very long time. No.
Okay.
And it's also good to note that among other classes of antihypertensive, it is not only Aldomate that has libido lowering effects. You can control beta blockers too. Beta blockers, they do. And of course, we still employ them. So what we're saying here is that just for a very short while, especially at the emergency, most of our patients with very bad BP.
Okay. Okay. Thank you. Thank you.
Thank you very much, sir.
Thank you for the duration.
Thank you very much, Dr. COOKEYGAM, for that question. At least we are gaining more insights in the management of hypertension. So thank you very much, Professor Simeon, for your contribution so far. It seems like there are no more questions.
I have a question.
Okay, you have a question. Okay, go ahead.
Yes, the question is directed to Prof.
Okay.
For the BP range of 90/70, I think that is okay for, I think what the person that asked the question is asking about maybe a blood pressure, say 80/50. When you measure the mean arterial pressure, you're getting like less than 60 millimeter mercury. I think that's the question. I don't know if Prof can just clear the air. With a blood pressure, say 80/50 millimeters of mercury.
Okay. So, Professor Simeon.
Yeah, thank you. If this is, I'm not sure whether you are talking about a hypothetical issue. What I've said is still applicable. What is the usual blood pressure of the person? The usual blood pressure is 80/50. That is okay. Usual. If the blood pressure has fallen from something else to 80/50, that is abnormal. That is hypotension. In the case of the first one, usually the patient will be asymptomatic. That is normal blood pressure for that particular patient. In every situation, you will have the nomogram distribution. You will have the greater percentage, almost 95 or so, 96 in the normal distribution. You will always have the extreme at the end. So this 80-50, sometimes you can have it at that extreme end, 0.00 something percent of patients. As long as the patient is asymptomatic, that is not a problem. In case the patient is asymptomatic, I can almost swear that it is caused by another problem, and your attention will be directed to that problem. And as I mentioned earlier, what your mind will come into, are you on antihypertensive medication? Fine. If the patient is not on antihypertensive medication, is there any acute cause of hypotension, like shock? Is there Addison's disease, that may cause all the sodium, aldosterone, everything on the low side? So hypotension, we talk about primary hypertension. There's nothing like primary hypotension. If hypotension is a disease, there must be a cause. Find out the cause and treat the cause, in addition to acute management of a patient whose blood pressure suddenly drops. I don't know whether your favor is okay with this explanation. Thank you.
Thank you very much, sir. I think that explanation is on point, because if it's blood pressure is unique for each individual, patient's normal blood pressure is 80-50, then there is no problem. But if it fell from a certain level to that point, so once you fix the shock, once you fix the cause, then definitely the blood pressure will rise back to an appreciable level. So thank you very much for all our participants. Let us not lose sight of the fact that hypertension is a big burden to Nigeria, to the healthcare sector in Nigeria. And also let us not lose sight of the fact that Neimeth International Pharmaceuticals PLC, we are here to provide quality medications for our physicians to be able to appropriately manage their hypertensive patients to goal. And as a result of that, we have Amlova, which is amlodipine, 5 and 10 milligrams for decades. Amlova has been consistent in helping patients manage their blood pressure. We have Nomoretic, widely used as a diuretic of first choice in the management of hypertension, containing amiloride, a potassium-sparing diuretic, and hydrochlorothiazide, a thiazide diuretic. We have Nodwet, which is amlodipine and hydrochlorothiazide combination. And we also have Miniplus, a prazosin and hydrochlorothiazide combinations. So please, as we leave here, I want to implore that we have it at the back of our minds to recommend and to prescribe and dispense these drugs to our patients. And that is one way in which we can help them to appropriately manage their blood pressure. So at this point, let's call on the Executive Director, Sales and Marketing, Pharm Roslyn Oputa, to just say a word before we end the webinar for today. So over to you, Ma.
Good afternoon, everyone.
Good afternoon, Ma.
Yes, I want to appreciate our host, Professor Senior Dr. Kaya Diadeshona. I want to appreciate you so much for finding time. Dr. COOKEYGAM, our own colleague. Thank you. You always responded to us and called on you. We appreciate your professionalism. UPTH is a very good institution that deals more on a great.
There's an echo. Can't hear you properly. There's an echo.
Our participants want to thank everyone. We've taken note of everybody that attended. We'll be getting back to you, not only with the presentations, but we'll be communicating with you and making sure that all our reps get to meet you regularly. Charles, I want to appreciate you for putting this together. You're always a very detailed and effective person. Thank you, and we hope that by the time we call everyone next time, we'll come back to another very much more enlightening webinar like this one. So thank you all, and God bless you. Prof, I'm sure we'll find time to come to Sokoto to see you, sir.
You have abandoned us.
We will, no, we'll be in Sokoto, sir.
Neimeth has abandoned us in the desert.
Prof, I have in my mind always.
Thank you very much. We'll be expecting you.
We will.
All right. Thanks a lot.
Dr. COOKEYGAM,
good work. Excellent work.
Every doctor, pharmacist, nurse, and all participants, we say very big thank you. The press, I've seen a couple of them. The gentlemen of the press, we say a big thank you. Let's all work together to keep this help to manage it and save a lot of lives. We've all listened, both even the healthcare professionals and the non-healthcare professionals, and today's webinar has been very enlightening and very much interesting, and I'm sure it's going to add value to a lot of people. Thank you, and God bless you.
Thank you. Thank you.
Thank you very much.
He's unavoidably absent, but we'll convey the outcome of the webinar to him. Thank you all.
Thank you too.
Thank you, ma.
Thank you so much.
So, Professor Simeon, thank you, ma. God bless you, ma. Thank you, sir. God bless you, sir. Dr. Kayode, thank you very much. And Dr. COOKEYGAM, thank you very, very much.
Thank you,
Dr.
Charles.
Waliu,
thank you.
and all other doctors that were here and made a contribution. Thank you very, very, very much. We are really, really grateful indeed for this honor donors. And we are going to see you again. We'll come to your hospitals, we'll come to your premises, and by God's grace, we are going to host another webinar next year, and we would still love you to be a part of it. Thank you very much.
Thank you. Thank you. Thank you, Dr. Adewale and TRICIA. Bye-bye.
Bye. Thank you so much, sir.
Thank you. Thank you.
Bye.
Yeah.
Okay, Prof. Prof, safe journey. Okay, you are not even in Lagos.
Thank you, Dr. K.
Yeah, zeros. I'll call it that.
It's okay, thank you. We'll have to log out now. Thanks.
The plot alone, now money, the place of not